pterygium. You might be knowing pterygium. Mostly the all related to questions, theoretical part of view and the clinical also. Maximally in the clinical posting, that is the cases are coming to OPD. Short case is given to you. And the theory part, what is pterygium, what is the etiopathogenesis, what are the signs, symptoms, how will you treat the case of pterygium, and how will you prevent the recurrence of the pterygium also. So very, very important topic. What are the surgical methods, what are the complications, that we have to discuss today. It's an important one. Anatomy of the conjunctiva, as we have said, there is a limbal part of the conjunctiva, palpable part, and that part. Forget about histology of the normal conjunctiva. You might be knowing there are three. If you take the history, the histological section of the pterygium, this conjunctiva, do you know what are the layers? Whenever I am talking about the conjunctiva, I am telling you the layers of that. There are three layers. What are those? Because the picture is not labeled that. One is the epithelium, superficial part. Then subepithelial or the adenoid layer, where the lymphocytes are all fibrous tissue in the cells they are found. The lastly is the fibrous tissue. So this adenoid layer comes after 4 months. That contains the lymphocytes. That is why trachoma is not found in before newborn, before 4 months. That comes up. That is the histological section of the conjunctiva. That you should know that. Definition, should know that. Derived from the Greek word pterygium means wing shape. That is the wing shape. The non-malignant, slow-growing proliferation of the wing-shaped fibrovascular tissue arises from the subconjunctival tissue. May extend over the cornea, thus disturbing the vision. After the degeneration, there are so many etiological factors. Most common etiological factor of the pterygium is the UV rays. You know what is the UV rays? In the light there are so many rays of infrared, UV rays and that. The UV ray is the lowest spectrum, lowest wavelength. It is absorbed by the conjunctiva. It causes the degenerative changes. The highest is after the red color, that is infrared rays. You might have heard the infrared rays also. Because these infrared rays, they pass directly from the cornea, lens and that, and they are absorbed by the retina. That is why retinal burn or the macular burn due to the infrared rays. So these are the UV rays, they are absorbed by the conjunctiva. This is the main factor, the etiology of this UV rays. It causes the degeneration of the subepithelial tissue, elastic degeneration. Whenever there is a degeneration, there is fibrovascular proliferation, and that is encroaching the cornea, destruction of the Bowman's membrane and the epithelium, and coming over the cornea and the later stages. This is how it forms the pterygium part. That is the definition: a wing shape coating the corneal part. Epidemiology is more in the dry and dusty areas, because the UV rays and sunlight is more in dry areas in the hot season. So many districts, that especially in the Rajasthan, there are Badme, Jaisalmer, where this is Dholpur, there are more hot areas that are more sun rays. So UV rays will be more, causing the degeneration part of this. Etiopathogenesis is a strong association with the UV light exposure. As I explained, that is the more common in the patient who work outdoor activities, they are more exposed to this. So if anybody asks you what is the most common etiological factor for this pterygium, and that is the UV rays. Others also, there are dust particles also, and there are some allergens or the infection also. Some say this is a viral infection also, but most common is the widely accepted, that is the UV rays factor. The more absorbed. And one thing more I want to tell you, this is more, pterygium is more in nasal side. It can be in the temporal side also, but the more in nasal side. There are two regions of being in the nasal side. One is, suppose there is exposure, more sunlight, the uniform exposure towards the nasal side as well as the temporal side, UV rays exposure. There is one, if you see that there is a nasal bone here in between, whenever the light comes from the front or the side by side, it goes the direct exposure to the nasal side and temporal side, plus additionally the nasal bone, because the nasal bone is not absorbing, it reflects over the pterygium nasal part. So additional, there is a reflected UV rays part in the nasal side. That is why the more radiation of the UV rays in the nasal side, because of the reflection of this nasal bone, because it cannot pass through that. So the more reflection of the nasal side, one part. Exposure is in temporal and nasal, both sides are same, but additionally because the reflection of the nasal bone, the nasal side, the more exposure in the nasal side. The nasal pterygium is more common. More one factor. Second factor is, if you see the anatomy, if I have read the anatomy of the nasal side, there is a caruncle and there is a lacus in between. Whatever the secretion of the aqueous comes in the pharynx, and that comes in the lower lateral part and the nasal part, because the punctum and the all lacrimal sac, they are drained there. So there is a pooling line in the nasal part because the lacus structure is there. So whatever the tears or the foreign body or infection or the dust particles or whatever they are for, they remain for a longer period in the nasal side as a pool material. So whatever the irritant or the infection or the dust particle or whatever, they remain for a longer period. That causes the irritation and this more additionally the pterygium. So the nasal is the two causes, because why this is common in the nasal side. One is the exposure from the nasal reflection side. Another part, there is a lacus of the more irritant and infection with dust particle. They remains there as a pooling for a longer period. So that causing the degeneration and the infection or the inflammation part. These are the two main reasons. Remember that this is the common question. But I ask, and usually whatever the external or internal examiner, they ask. First they will ask, suppose the case is given to you, they will ask which side this is more common. Your answer will be nasal side. It can be in the temporal side also. Why? Then question will be why. Then you remain silent if you don't know. The answer will be, so there are two factors. One is the nasal side, there is a reflection from the nasal bone side. Another is the lacus or the nasal cancer. There is a pooling of that more particle and that remains for the longer. That will be your complete answer. That is why the more common thing is. It can be temporal, it can be nasal, it can be both sides of this one. That is the two main regions of this. Dry and dusty environment, the same thing, when the more irritant as that. Genetic predilection has no meaning. Pathology, that is the elastotic degeneration of the collagen fiber, because the all conjunctival fiber, they have all the fiber, they are the UV rays cause elastotic degeneration of the fibers. Whenever the degeneration is there, then later the fibroplegia occurs of the conjunctiva, and slowly it encroaches over the cornea. It destroys the Bowman's membrane, the epithelium, and slowly progresses inside the pterygium part. That is the etiopathological. But the main thing is it causes elastotic degeneration of the conjunctival fiber part, and then progresses toward the corneal part. Still we have no meaning. Then stages comes. What are the stages? Stage 1 is the exposure conjunctivitis. Suppose the more exposure, this causes the inflammation of the redness part. That is the first stage. Then the pingacula. Pingacula is the precursor of pterygium. Degeneration of the conjunctiva, a triangular fold just near the limbus, and that is the precursor part of the pterygium. And later on, limbal pterygium. It looks just like pterygium part, the triangular tissue that remains up toward the limbal side. And then comes the corneal pterygium. It encroaches over the. These are some stages: the conjunctival, the limbal part, the corneal, and then the compound pterygium. It can occur in the both sides also. So this is how these are the stages. Before that stages, we are also classifying that gradings of the this pterygium part. That is given in your books also. Less than 2 millimeter is up to the limbus, the 0 grade. Over the cornea, less than 2 millimeter is the grade 1. 2 to 4 millimeter, grade 2. It crosses the limbal, this pupillary area, That is the grade 3 there. That is how we divide. Less than 2, 2 to 4, or more than 2 that. It comes in the pupillary area, that is the grade 3 part. That is how the stages and the gradings we have divided. And come the parts of the conjunctiva. Fuchs patches, the Stoker's line, the hemosiderin deposition of that, hold the head, body and base, superior edges of the inferior edges. A triangular fold is there that you have to remember that. This is the main picture of this one. Many times, usually I ask, suppose the case is given to you, I ask the candidate, the student, draw a diagram of a pterygium. You have to make the triangular floor. Then I ask, label these. Then you should know what is the head, what is the neck, Stoker lines, the body, and the base, superior margin, upper margin. So these things you must know the label part of it. Can you tell me this? What will be the grading of this pterygium? Looking at this picture, look here. See carefully this picture. How much it is involving to the pupillary area? Pupillary area. Definitely it should be more than 4 millimeters, covering the pupillary area. So grading 3, more than that. Which picture, what the patient will have the complaint of this picture like? Patient will complain of diminution of the vision. Yes, patient will, because this has come in the pupillary area. That one thing more, whenever we feel the complaint of this one, patient may have blurring of the vision if this is not covering the pupillary area. Suppose this is up to the limba, the less than this, up to the pupillary margin. Pupil is clear, not coming the pupillary area. Then the patient will also have blurring of the vision. Do you know the answer? Anything? Why this pterygium causes blurring of vision even this is not covering the pupillary area? You know what is astigmatism? Have you heard the name astigmatism? Astigmatism is there are two principal axes, one rays and another rays. They are principal focus at a one point. Astigmatism is they are focusing at a different point. They are different meridian, they have the different focal line. Just think of this is a fleshy part, thick fleshy part coming in this meridian. This is the horizontal, this is the vertical axis, this is the horizontal axis. Thick part go on pressing little bit. So this corneal axis, this curvature will be little present. That gives a astigmatic sign. So even then, if this pterygium is not covering the pupillary area, patient may complain diminution of the vision or blurring of the vision. The reason is a astigmatic effect. So the blurring of vision causes by two means. One, the pupillary area that comes, that causes. And this is the astigmatic effect causes the pressing of the corneal curvature, that is giving this part. That is one. Another important point. Patient may complain of diplopia in pterygium. You know why? Because this is a fleshy tissue and degenerational part. If there is a restriction of the movement, the one side, the nasal or the temporal side, then there may be diplopia. If the muscles are involved and thick band restricting the movement, then it can be given the diplopia toward that movement because of the thick and restriction of the movement. Remember that patient may complain diplopia also. If post-operatively, if the patient complains the diplopia I have occurred post-operatively, not before, it was not before, the reason will be we might have injured any medial recti or the lateral recti while excising the tissue. So pre-operatively, it may cause the fleshy part of this one, restriction of the movement. The post-operatively, after cervical, touching the or injuring the muscle part. Remember these things. Then clinical types of the pterygium. It can be progressive, it can be atrophic part of the membranous part. Progressive means thick, fleshy, marked vascularity. That means fleshy part we have seen. That is the progressive part. Stoker's line that go on progressing. Atrophic means membranous part is not going to open. That is the progressive or atrophic part. Atrophic is the thin, attenuated, poor vascularity and the no cap. You can see that this is the progressive type or this is the atrophic type. Stoker's line is the hemosiderin pigmentation deposition just after the head or near the cap. That's what it is progressing in nature. That other type primary double pterygium, recurrent pterygium, pseudo-pterygium, malignant pterygium, pterygium with restriction of the ocular movements. The word is pseudo-pterygium, you must know it. Whenever we will take in differential diagnosis, the pseudo-pterygium will come across. We'll see the features, how we'll differentiate with this one. Double pterygium involving this one, both sides. Sign and symptoms. Some we have discussed, some asymptomatic patient may not have any symptoms like that. Foreign body symptoms because it face at interlocular margin, discomfort, congestion of the redness, irritation and the grittiness, precorneal tear films, interference with the vision, obscuring the visual axis, induced astigmatism. Two things are clear which I have explained before. Interference of the vision, that is the visual axis when it comes, and astigmatism effect. Remember that. Signs will be extending in the 2 millimeter, 2 to 4 millimeter, 3 millimeter, we have discussed that. Then coming to the differential diagnosis, the pseudo-pterygium. A pseudo part. That's like it gives an appearance of the pterygium. Pterygium is usually degenerative. And pseudo means giving this picture, but this is not the degenerative part. There are 3-4 differences. Pseudo-pterygium is the age restricted. That can occur in any age. But the pterygium mostly is in older people or the elder people. Sight. The more in pterygium is the more in the palpable part. Pseudo-pterygium can be occurring anywhere. One is inflammatory condition. Pseudo-pterygium. Inflammation means any conjunctive trachomatis like that, or chemical burn or other things. While the pterygium is a degenerative condition. It is not an infective part. That is one. And pseudo-pterygium generally remains stationary, and pterygium may be progressive also. Last differential diagnosis, last difference, we can pass a probe in between that. In the case of pseudo-pterygium and the pterygium, we cannot pass. So these are the 4-5 differences of the pterygium and pseudo. Usually ask these things. So one difference is the age difference. Any age more in the elder. Location, the more in the palpable part, that can be anything. Causes, infection and the degenerative part. Probe can be passed there or not. These are the differences. That remains stationary or it can progress also. So these are the differences of this one, pseudo-pterygium and pterygium. Coming to the treatment part, medical and surgical. Medical, usually we cannot treat. Once there is progress on that part, medically we cannot treat that. But some relief we can give to the patient. Symptomatic patient, tear substitute, because there is many times there is a dryness and that grittiness, that will have tear substitute. Inflammation is there, that we can start with topical steroids. Sunglasses just to reduce the UV rays part, or you change the environment whether the sunny rays, just the dark type or where the sun rays is not common. Then coming to the indications of the surgery part, because the main treatment is the surgical part. Extension to the visual axis and induced astigmatism. If this is coming toward the pupillary area and gives the astigmatism part, then surgery is required. Recurrent irritation. Cosmetic, if the patient is worried, then you have to remove it. Coming to the surgery part of this one, there are so many types as the name indicates of surgery part. Simple one before that we were doing simple excision. Simple excision means just lift that head and neck part, excise at the limbus and leave as such. These cases will recur. Mostly the recur because the causative element we have not implanted anything there. That is the recurrence part. Other part is free conjunctival autograft, the primary and the recurrent pterygium. Autograft, the same eye, you remove that, take the conjunctival autograft from the limbal side, having the limbal stem cells, and you implant that part after remove that. That is the main part of the surgery. It has two. One, we have diseased conjunctiva, we have removed. That has gone. So there is a positive organ, positive part that has removed that. Second thing, whatever the graft we are taking, this is attached to the limbus part. This limbal conjunctiva that contains the limbal stem cells. So it will regrow the same tissue. That is the best treatment part of this. So simple excision you can do that, or rotation also. What is conjunctiva that we have taken, cut that and you reverse that and implant that. That is the part of it. Or this is autograft, the same conjunctiva. Or amniotic membrane graft, we can do that. Amniotic membrane, then we can implant or suture that part. The best treatment of the conjunctival just to prevent the recurrence is the excise and conjunctival autograft. That we have to implant that. There are three ways. Many times I ask, how will you adhere that? How will you implant? How will that implant or that tissue will remain in position? Because that comes in your mind. Suppose we have excised, we have taken the graft, we have put there. Now what to do? You should attach there. There are 2-3 ways. One, there is a glue. Serum glue is ready-madely available. Spread that and that will adhere, that will remain in position 1. Or if you don't, because the glue is costly then. 0.5 cc costing a 3.5 thousand rupees. Everybody cannot afford this, poor patient. Then suture that. 5-6 sutures we can implant that. Third is the recently invented, that is the auto serum part. Remove that part, some scraping of the serum or there's a blood clotting is there, take the graft over side, spread over there and just press that and wait for 10 minutes. That will adhere because after the clotting that tissue may or will remain in position. That is called auto serum part. That is the third part. So either the glue or the suture or the auto hem part we can do that. These are the some ways of the just to adhering or uniting that tissue part. That is the treatment of the surgery of this. Excision, we have excised that. This is how this picture shows the excise and then the graft. This is the second picture after that, after the removal of the fibrin or the sealant that is got, that is the glue, conjunctival autograft. I spread it, that will adhere that. They are readily available. Complications. The graft we have implanted. What complications can occur? Another one complication, suppose the pterygium, if you have not touched, you have not treated, you have not excised, what will happen? Either it will get infected or cystic degeneration, or it can change into malignant fibrosarcoma or fibrosarcoma. So these can be the fate of the pterygium. Remember that. Many times we ask you, suppose we don't touch the pterygium, we don't excise, what will happen? So 3 things. It can infect it also, there is cystic degeneration also. First it will form the cyst, then or it can change into malignant form also. These are the fates of the pterygium. After the surgical technique, what complications can be there? A graft failure. Graft can be failure also. The rejection of the graft. Granular formation, conjunctival infection, suture detachment, delayed healing. That can be, these are some complications of that. other complications after the scraping, we can perforate also, then tissue or uval pigmentation, that symptom, or then infection of the endophthalmitis or whatever the thing is. That can be there. So these are some common complication can be occur. Other surgical, bare sclera that we have discussed, simple closure technique, all complications, scleral perforation, pterygium recurrence. Pterygium recurrence is very, very common. Just after excising, if you leave as such, because whatever the factor is there, that will go on the subepithelial or subconjunctival tissue degeneration. That will go on increasing fleshy tissue and across the cornea later on. It will recur until unless you prevent that progression, either the autograft or by cautery or mitomycin C if you start with. Mitomycin C is a chlorophyll that will act anti-mitotic activity, that prevent the growth of the tissue, that also, or the irradiation thiotepa also. We can do that also. That is how we can prevent the recurrence. Adjuvant therapy, corticosteroids, how we can start. No significant role in prevention of the recurrence. Recurrence is not going to stop with the steroids. Mitomycin, I told you after excising we can start that anti-mitotic activity. So many side effects of the mitomycin C that will come after that. Thiotepa also irradiation. Cyclosporin A also, that is also an anti-mitotic activity that we can start. This is the intermediate that we can give. Beta radiation, amniotic membrane graft we have discussed. Membrane application after the pterygium, you can see that how it looks like amniotic membrane graft. Complication we have seen that one more thing in surgical action. Suppose the more in corneal area, remove that. If the cornea is involved in more in the thickened part, that you do that keratectomy, because we have to remove that superficial part of, and then a lamellar graft of the cornea also we can do. Just after this is all the things, keratectomy plus partial thickness graft, we have to do that. These are the surgical methods. So far we have seen that what is the pterygium, what are the parts of the pterygium, what signs and symptoms, the blurring of the vision, there are the regions, types and the gradings of this one, pathogenesis we have seen that, pseudopterygium, what is differential diagnosis and how to differentiate that, and the treatment part of the pterygium. Simply remember that, excise and remain the autograft. Mitomycin or the cyclosporin or the thiotepa, or these are the secondary, or steroids are secondary things. But important is you implant or get a tissue implanted this one. 3 types, one is suture or the glue or auto heal plate. But there are certain complications, this you have to remember that. So that finishes your small topic for the short cases pterygium, but it usually remember. I advise you just go through that, read again this one. What is the gradings, what is the etiological factor, sign and symptoms, why the diplopia occurs, why the blurring of the vision occurs, what is the differential diagnosis, what is the etiological factor, how the UV rays act, and the differential types of the treatment, what are the surgery different types, and what are the complications of the surgery that should go through. Either you will get the clinical case or the theoretical case, that will be the important topic of this. Practically also in the outdoor part that is common. That finishes, I think, this topic, the pterygium. And next time we will start a new topic, either the uval tissue